بس ممكن تعملي بس
انا بيكتب انا بتكلم معاها قبل انا بعمل لها الاوديو ماشي الاوديو كان عندها حوالي 60 سنه بيجاوبوا معايا على انها نون اس ار تي والديسكريميشن مش ماشيين معاها خالص ولكن الفول سبيتش ديسكريميشن طلعها بلاتر النون الاوديو هي الست مش فاهمه هي الست كل شويه بترفع ايه عايزاني هالاوديو اكتر مره هي مصره على اجابتها لا انا بسمع كويس هي مصره انها سامعاني كويس ودخلت عملت لها بي ان جي لانها المشكله بتاعتها الاساسيه بيجي لها اتاك سسبنسيشن ديفيكالت ماركتنج تايم زي بتكون بتضغط على الخط تقع عملت لها بي ان جي عندها بايلاترال عندها سنتيريال سباينس بيقل فيكسيشن عندها بوزيشنال سباينس في كل بوزيشن هيد رايت هيد سنتر وهيد ليفت الكالوريز بتاعتها وعملت لها الكالوريز طلعت عندها اللفت نورمال كالوريز والرايت ويكتر طيب هي البيشنت تسليم البيشنت دي قعدت معايا اسبوع لحد ما وصلت للدياجنوز بتاعها هو السبيتش ديسكريميشن بتاعي قليل في حاجه غلط الرايت عندك ديسكريميشن واللفت نورمال وانت مجاوبه في الاثنين رايت اوديو فنورمال اوديو في الاخر طلع في البيشنت سيفير سنسوري نيورال في الرايت سايد بعد لف كتير يعني
بس انت قلتي ان الاوديوجرام الاولاني بتاع
هي نورمال she confirmed that she is normal.
The patient.
Yes, she is confirmed. Every time normal.
False. Just in conclusion, she has right severe sensorineural injury and right tibial lesion with spontaneous nystagmus and the positional nystagmus. So this right sensorineural hearing loss with right uncompensated vestibular. That's what is included in the cochlear.
عملنا لها انا عملت ام ار اي قبل ما اتاكد من
Let's stop here. When the patient answers yes, you got a normal audiogram, right? And then you're not quite sure yet what's coming. What should you do?
انا يعني ثينك ان هو لو في مثلا اسيمتري احنا عملنا ديسكريميشن اس ار بي اهي انا ممكن اعمل ماسكينج انا لو هعمل ماسكينج يعني الديسكريميشن كانت مثلا رايت ديسكريميشن نورمال والليفت هي ديسكريميشن جايبه نورمال اوديوجرام لا هعمل ماسكينج في الرايت حتى انا مش انديكيتد اقول لا
I don't want to talk about testing. I know you can do all of this masking, you can do even pseudo-hypothesis testing and all that. You have an audiogram and you're not quite really sure that the audiogram is right. Killing 4. 256, 1,000, and 4,000. Yes. I mean, that you're looking at the patient. And in a severe sensory neural, in this case, before the MRI, you put the 256 and it's going to go to the right ear or the left ear, whichever the good ear is. I mean, it's fine you did the MRI, but what I'm trying to tell you is there is something called clinical medicine. You have to know how to do all the clinical stuff before you go and order unnecessary stuff. And the truth is, EEG, whether here, England, States, the only thing that's useful in EEG is the caloric test. We stopped doing EEG in my practice for years. It's just for making money here and there. That I know I'm touching upon some sensitive issue here. Because all psychotic eye movements, you can see it in the office. Positional test, you can do it in the office too, with the forensic glasses. But the calorics, you could actually do calorics in the office if you wanted to. So you don't need to be stuck with a report coming from Cleveland Clinic saying unilateral vestibular deficit. We've seen it all the time, oscillatory exit. We've seen incorrectly read vestibular audiograms, ABRs. We've seen ABRs that's absolute noise and saying elevated SPAP wave 5 and 3 are delayed, and you don't see anything. It's a disaster. It's a world disaster. Professionals order tests, don't know how to read them, and when they get reports, they act on the reports because they're coming from, you know, XYZ hospital or doctor. You need to know how to justify your own reading. So when you get say an audiogram, particularly mixed hearing loss, just use the tuning fork to figure out where is the conductive component is. So let's go back to the person that said, I don't know how to measure the standards. Fine. This is a caloric test. You know, right ear, left ear, and that's a positional test, horizontal and vertical. So when you look at any nystagmus signal, this is a kind of a little bit of an active or overactive nystagmus. Let's look at that one. That is post-fixation. You can see that there is an excellent fixation here, right? Right. Here is what you need to know about reading nystagmus. You look at this and you say, all right, I have, that's a slow phase because it takes longer time to complete. That's a quick refixation, the repositioning of the eye. Slow, quick, slow, quick, slow, quick. So the quick phase component going down in a horizontal channel configuration. And that's a left beating nystagmus. Okay? Also, we know that cold opposite warm C. When you stimulate the right ear with cold water, you get left beat nystagmus. That's left beat nystagmus too, but it's overactive. All right, so that's number one thing. You know that. Now, how do you measure it? The easiest way to measure that is to get a piece of paper, any piece of paper, a card or something. Let's see, all right, so a card like that, and you know that this is 10 degrees, and that's 1 second. All right, 10 degrees, 1 second. You could take anything. That's 10 degrees, 1 second, or that's 10 degrees, 1 second. So that's your slow component. First one, the second one, third one. So you kind of scan through that. The speed of this beat is, when you come here, it's taking half a second to get up to 20 degrees. So it's 40 degrees per second. Because that's 10 degrees per second. And that is also 10 degrees per second. The line that's parallel here is 10 degrees per second. So that line is twice. So this is somewhere between 20 and 30 degrees per second. You can do the same thing here. That's your slow phase component. That's my slow phase component. Slow phase. Because it's not connected, it's not that. So that's your slow phase component. It's very high. So you take 10 degrees and how many, half a second or say 1 second, and how many we're going to go? That's 10, 20, 30, 40, 50, 60 degrees per second. So that's how you measure. It's a slide rule, trigonometry 101, so to speak. You find out how many degrees the eyes move in 5 seconds or 10 seconds or what have you. Let's take an easier one. That's a left fold, so we're getting right medium status. It's a little bit hard to see here, but if you come here, all right, that's your slow component going down, quick up, slow down, quick up, and so on. So your up component, the quick component's up to the right. So that's a right leading the standard. And that's correct direction because it's a left, cold, caloric. How we measure the speed. You look at this is a good response. Now, is that a response? No, but you don't want the computer, the micromedical, the XYZ, the star key, I'm not picking up on the micromedical. They're going to give you a number here. But the computers are stupid. Computer in this tracing will give you that slow component, slow component, slow component. We'll give you about 3-4 degrees per second.